So phase 3 randomized controlled trials are often costly and can take years to carry out. They may involve hundreds or thousands of participants cared for by clinicians, nurses, and other medical professionals at many sites. They aim not just to increase the sum of human knowledge, but also to improve treatment, care, or prevention for future patients. To achieve this, the results need to be communicated effectively to a variety of audiences. We've already heard this morning about communicating with some of those audiences. The evidence base on how best to communicate trial results to different audiences is sparse, and it's estimated to take around 17 years for trial results to change clinical practice. These gaps in evidence mean that scarce time and resources may be wasted in carrying out ineffective communications activities, while approaches that do work may not be widely used, meaning clinical practice may not be based on the latest reliable evidence. This study aimed to examine the effectiveness of different methods of communication of clinical trial results to professional audiences. As my role at the MRC Clinical Trials Unit focuses on communicating the results of our studies, I have a very personal interest in this topic. I spend my days trying to encourage policymakers and healthcare workers to use evidence-based approaches, but my own practice is not evidence-based. This was my motivation for doing this review. So our population was healthcare professionals, policymakers, guideline developers, and healthcare commissioners, not restricted by setting or demographic factors. We were interested in approaches used for communicating study results from phase 3 trials, systematic reviews, or observational studies. We did not restrict by comparator. Our primary outcome of interest was impact, such as changes in policy, guidelines, or practice. We also looked at other types of impact as defined in the International Association for Measurement and Evaluation of Communication frameworks, the AMEC framework. So that included outtakes, which are the response and reactions of the audience to the communications activity, and outcomes, so the effect of the communication on the target audience. We carried out a systematic review of the literature published between 2000 and 2022. We searched 4 major databases and grey literature sources. Our inclusion criteria were broad with regard to study design, setting, and disease area. The full text of any potentially relevant articles were assessed for inclusion by 2 reviewers. Data was extracted and risk of bias was assessed using the appropriate risk of bias tool for that study design. Our full protocol is available online and is registered with Prospero. So our synthesis approach, we grouped our included studies by intervention type. The studies eligible for inclusion had diverse settings, outcomes, and study designs, meaning that meta-analysis was not appropriate. Instead, we used effect direction plots to synthesize the results across studies. Findings from similar outcomes within each study were combined into a single outcome domain based on the AMEC framework, with impact split into 4 subdomains: impact on prescribing, impact on other practice outcomes, impact on policy, and impact on health outcomes. We derived an overall direction of effect for each domain or subdomain reported in each study. So to be classed as beneficial, the direction of effect of at least 70% of outcomes in that domain within a study must be benefit from the intervention. And to be detrimental, the direction of effect of at least 70% of outcomes in that domain within the study must be detriment. If it did not meet either the benefit or detriment criteria, it was classified as no change or inconsistent. We also looked at qualitative aspects of it as well, including the factors that influence the effectiveness of different communications approaches, and also the views and experiences of the different audiences and those involved in communicating trial results. The qualitative analysis was done using a thematic analysis approach with inductive and deductive coding informed by concepts from the information seeking and communication model, which was published by Robson and Robinson. This analysis is still ongoing, so I can only share a few of the results from the qualitative side of it today. We found 17,000 articles for screening, of which 3,762 were removed as duplicates. 13,264 studies were screened by title and abstract, of which more than 12,000 were deemed irrelevant. 416 full-text studies were assessed for eligibility, excuse me, of which 325 were excluded. 89 studies related to lay audiences, so aren't included in the results I'll tell you about today. 59 studies were deemed eligible for inclusion in the review. 21 of those assess the effectiveness of communications interventions, so are included in today's quantitative results, and the others contribute to qualitative questions. For the quantitative analysis, included studies were grouped into 4 categories based on their interventions. So firstly, outreach interventions, knowledge broker services, researchers repackaging the results to make them more appropriate for the target audience, and summary formats for systematic reviews. This could be considered a subset of either of the 2 previous categories, depending on who is producing the summary. However, as specific formats have been developed for summarising the results of systematic reviews, such as summary of findings tables, which do not apply to the results of individual clinical studies or other studies, it's considered here as a separate category. Starting with outreach interventions. All the interventions included in this category involve face-to-face meetings between the target audience, which was healthcare practitioners, and trained educators. For some studies, these were individual meetings, whereas others took place in groups with practitioners from the same health facility or local area. In addition to the face-to-face meetings, in some studies, the target audience were given materials to support the messages communicated through the meetings, such as reports or educational materials, newsletters, reference cards. Some of the interventions focused on presenting the evidence, whereas other more intensive interventions also sought to address the change process needed to implement the recommendations. Interventions were delivered by clinicians, pharmacists, or research nurses. Some interventions involved one-off outreach to target audiences, whereas others, which focused on the change process, in addition to the evidence, involved more sustained contact with the target audience over a period of time. The approach was tailored to the specific audience in most of the interventions included in this category. So on this slide, you can see the effect direction plot for outreach interventions. Each row is a different study, and the colour of the row indicates risk of bias, with green being low risk of bias, yellow some concerns, and red high risk of bias. Upward pointing triangles indicate benefits, sideways triangles indicate no change or mixed effects, and downward pointing triangles indicate detriment. The size of the triangles indicates the sample size, with the smallest triangles indicating fewer than 50 individuals in the intervention group, and the largest triangles more than 300. The most common outcome type assessed in these studies was impact on prescribing patterns. 3 of the 4 studies that reported these outcomes saw improvement from the outreach intervention. Both studies that looked at impact on other practices saw improvement following the intervention. There was no evidence of benefit on policies, but there was evidence from 2 studies that outreach interventions may lead to small improvements in health outcomes. Overall, the included studies suggest that outreach interventions may have an impact on practice. If you combine prescribing practice and other practice outcomes, the sign test p-value for impact on practice was 0.031, which could potentially impact on health outcomes. However, there's no evidence that these interventions can change policy. Combining results from all 4 impact subdomains, the sign test p-value is 0.031. The results suggest that overall outreach interventions have a benefit in terms of impact. Moving on now to the knowledge broker category. So they were all ongoing services that aim to identify relevant research and repackage the results in accessible formats for professional audiences, so policymakers and practitioners who subscribe to their services. These repackaged results take a variety of forms in different studies, including evidence-based reviews, position statements, guidelines, policy documents, evidence bulletins, and email alerts. A general feature of the repackaging is to summarise the research and results, making it more concise than a peer-reviewed journal article. As well as sending these summaries to the target audience by post or email, the knowledge broker services also tended to have websites that contained archives of their summaries that could be searched. The geographic scope of the knowledge broker services included in my review varied from regional to national to international. Tanner and Dormoff described regular monthly or bi-monthly editions of the knowledge broker outputs. The organisations acting as knowledge brokers were not always clearly described in the articles, but tended to be academic or non-profit organisations. So 4 studies evaluated knowledge broker interventions, but results were only available from 3 of them. With so few studies reporting results and all using different outcome measures, it's not possible to draw conclusions about whether knowledge broker services are effective or not. The effect directions from all 3 studies are positive, suggesting there may be benefits from this type of intervention, but more research is needed to explore this further. So moving on now to researchers repackaging the results. The results were repackaged in different forms in different studies, including an online continuing medical educational video, a face-to-face workshop, an abstract, plain language summary, audio podcast and transcript, different versions of policy briefs, and a 1-page summary. The interventions were all delivered as one-off engagements with the target audience. While the available evidence mostly points towards repackaging interventions potentially having an effect on outtakes, the relatively few studies and the quality limitation of these studies makes it hard to be confident in this approach, and more evidence is needed. With only 1 study contributing evidence on the outcomes domain, with some risk of bias concerns, there's even less evidence in this area. 5 included studies looked at summary formats for systematic reviews. One of the approaches studied was summary of findings tables, like you can see on the slide, with or without recommendations. Summary of findings tables present the results from the most important outcomes and quality of evidence scores from the systematic review on a single page in a standardized format. Another approach was grade evidence profile tables, which are similar to summary of findings tables, but provide more detailed information about the quality of evidence. Another approach included in this category include graded entry formats, which are reports which start with a short summary, followed by a narrative report and then a full scientific report, allowing the user to access the main findings quickly or explore the evidence in more detail if required. Another approach looked at was fishbone diagrams, which are a way of graphically displaying information in a very kind of condensed format. All 5 studies reported outtake outcomes. Of these, Van Wyk and Rosenbaum showed an overall benefit from the summary format. Van Wyk found improvements in comprehension outcomes, speed of finding the required information. However, there were no significant differences in accessibility outcomes between the 2 table formats tested, nor was one format preferred overall compared to the other format. Rosenbaum found that the summary of findings table improved understanding of results and sped up retrieval of information from a systematic review compared to the systematic review text without the summary of findings table. The other studies reported mixed effects on outtake measures. Apio found no significant differences in odds of correct responses to clinical questions, but the graded entry format was superior to the systematic review alone in terms of perceived value and accessibility, and was preferred by participants. Newman found that clinicians expressed a strong preference for having a recommendation alongside the evidence summary, rather than the evidence summary alone. However, the presence of a recommendation didn't improve knowledge about the subject. Garcelerner found that participants in the summary of findings table group were more likely to answer comprehensions correctly than those who were in the fishbone diagram group. Participants preferred the summary of findings table to the fishbone diagram, finding it easier to use and understand and less confusing. However, of those who correctly answered questions, those in the fishbone diagram group answered correctly faster than those in the summary of findings table group. Taken together, we cannot be confident that the different summary format studies do improve outtakes from systematic reviews. The sign test p-value for outtakes was 0.025. And as you can see for outcomes, again, there's very mixed from different studies showing different things. So we can't be confident about any of these formats improving outcomes. Moving on now to the qualitative analysis. So as I mentioned earlier, this analysis is ongoing. So today I will focus on 4 factors that influence the effectiveness of approaches to communicating study results. Firstly, the information being communicated, then the perceived credibility of the information and the information source, the communication medium used to communicate the results, and the information products used. What the information is that is being conveyed is associated with how that information is received by the target audience. The topic of the information, together with the specific information items contained within the results communication, are both influential. Some health topics have a higher profile than others. Hand found that the target audience's interest in the topic was one of the most important factors for healthcare professionals deciding what information to read online, along with credibility. Controversial topics may be more likely to spark interest, as were those that were seen as different in some way. Dormoth's analysis of the effectiveness of periodic letters at changing prescribing behaviours found that the impact seemed greater when the take-home message was to increase prescription of something rather than to stop prescribing something. This is something in our work at the unit as well that we've also observed. Genova found that the majority of the effective evidence-based materials she examined contained a limited number of key messages, 3 or less, suggesting we need to be selective in what we try to get across when we're communicating study results. Genova also found that less than half of effective evidence-based materials used positive frames for their messages, with most focusing on avoiding bad outcomes rather than improving good outcomes. Schmidt looked at briefings for policymakers framed around either saving lives or saving dollars, and found that economic concerns meant that the briefing framed around saving dollars was preferred by policymakers. Information items that were popular with users included background information, information about contextual factors that affect the local applicability of the results was viewed positively by participants in several of the included studies. While the focus of this review is on professional audiences, this does not necessarily mean they'll be familiar with all the technical terms used in research, making clear definitions helpful. Information about methods used to generate the evidence being communicated seems to be not very important to professional audiences. Kelly found that there was demand from doctors for summaries of the literature that included a grading of the level of evidence, but there were mixed opinions about the level of detail around quality review to be included when communicating study results. Several studies looked specifically at the grade approach to assessing the quality of evidence. BSERT found that German-speaking public health decision makers did not find the information provided from the grade ratings very helpful, often because they were unfamiliar with the terminology used, or because the labels given to the graphical representation of the quality ratings did not seem to match. There was a preference for just using the symbols without the labels, as it conveys information in a condensed way. Information about costs and health economics was found to be important to professional audiences, including both clinicians and policymakers, across several studies. Several studies found that participants thought summaries that did not provide concrete recommendations had limited usefulness. So in Newman's study, 86% of participants preferred having recommendations in addition to evidence summaries. And the presence of recommendations significantly influenced clinicians' intended course of action compared to just getting the evidence summary alone. Ellen found that all participants liked links to additional information and resources. Moving on now to credibility. By credibility, I mean the extent to which users trust and believe what is presented to them, and what elements of the product, the information product, influence this trust. The perceived credibility of communications material influences whether or not professional audiences engage with it at all. Hand's interviews with healthcare providers found that credibility, specifically the credibility of the source, was a key factor when deciding what information to read online. Having engaged with the communication, Kelly's work looking at physicians' perspective of translating research into practice highlighted credibility as a key issue in determining whether research evidence gets implemented in clinical practice. The included studies identified factors that influence perceived credibility of tools for communicating research results, including who is providing the information, the evidence base of the information, and the content of the communication, including perceived accuracy, transparency, and balance, but also the communication medium and how well it is written. The information provider came up repeatedly across many of the studies as a factor influencing how credible research results are seen to be. This was the case across type of audience, so policymaker or healthcare professional, and setting, so high-income countries or low and middle-income countries. In part, this is down to the reputation of the organisation or the author for carrying out high-quality research, and in part it is related to the potential for conflicts of interest. If a communication is coming from a trusted, familiar brand, professional audiences seem to take this as an indicator of the quality of research reported. Many policymakers don't feel equipped or have time to assess quality of research, so having a heuristic like this is a useful shortcut for them. Information coming from organisations that were seen as independent, such as NICE, was often perceived to be more credible or trustworthy. Conversely, communications coming from commercial organisations or lobbyists or from research sponsored by pharmaceutical companies were seen to have less credibility because of the potential conflict of interest. Including conflicts of interest statements in research communication materials may help enhance the perception of credibility. However, Genova's analysis of effective evidence-based materials found that only 1 in 10 actually did this, suggesting that the absence of conflicts of interest statement doesn't always act as a major barrier to influencing policy and practice. There's not a great deal to go on in terms of explaining how the communication medium influences the effectiveness of different approaches to communicating the results of clinical research. There are hints that the communication media that are chosen or developed specifically for an audience are preferred over communications media that are primarily targeted at other audiences. So it doesn't work sending something that you've developed for a different audience. Personal communication was valued by policymakers. There are also suggestions that push approaches are preferred by busy policymakers, so sending stuff out rather than expecting them to have to look for it. Thompson-Kuhn found that products that were easy to read and access were preferred to traditional scholarly communications tools, such as research posters or peer-reviewed papers, even in the context of a scientific conference. In Poland, journal articles are trusted by Polish policymakers, but they don't like them. They're not preferred source of information. Understandability seems to be an important factor influencing the effectiveness of information products. Studies that looked at summary of findings tables and grade ratings found that users often struggled to understand them, in part because of the terminology used, particularly the statistical terminology. While the results of clinical trials are usually communicated via peer-reviewed journal articles with a standard structure of background, methods, results, and discussion, several of the included studies presented findings that suggest that alternative structures are preferred by professional audiences. This includes putting what the audience regard as the most important information up front. In the case of UCC participants, this was information on the relevance of public health practice alongside key messages. For Rosenbaum, this is putting the summary of findings table near the front, and within the summary of findings tables, putting the key results first to make them easier to find. Ellen found that participants appreciated a summary page that outlined key messages. Many of the points raised about the layout and formatting of materials relates to how easy it makes a document to scan and locate information quickly. The use of clear headings was appreciated by information users as it facilitates that rapid scanning of the information and locating information items that users were particularly interested in. The use of formatting elements such as boxes, emphasizing information in bold or using color to highlight key points, was also popular with participants in UCC and the Jimbo Deve studies. Having too many visual elements crowding a page can make it seem cluttered, with participants in the Jimbo Deve study preferring a less crowded, uncluttered version of the document. Those developing materials for professional audiences need to walk a line between making the document clear and attractive and easy to use, but not too expensive looking. The information density of an information product could hinder ease of use of the product if the information is too dense. This is particularly a problem in the summary of findings tables. Allowing users to obtain a quick overview of a topic can be an advantage. The length of documents it seems to be important to users. Documents that have too much text may be viewed as not user-friendly. However, longer documents are not necessarily a disadvantage if they are easy to scan and allow users to extract the information they're interested in. And while users generally wanted summaries to be concise, they also often wanted additional information to be included. Tables were appreciated by some users as a way of rapidly accessing information. Majumbe Debe found that poor initial understanding of the type of information product and its uses was a major problem, with a mismatch between users' expectations and what the information provider wanted to communicate. So limitations of this study, obviously the studies included are very different from each other, and there is insufficient evidence to draw conclusions from knowledge broker services and researchers repackaging results. So there's still a lot of kind of uncertainty around the results there. So there's good evidence that outreach interventions communicating study results can improve health outcomes and change practice, but they can also be resource intensive. Knowledge broker services may have an impact on clinical practice, but there was insufficient evidence to be very certain about this. And there was limited evidence to support any of the interventions in terms of impact on policy, attitudes, or outtakes. Work is ongoing analysing qualitative evidence around the factors that influence the effectiveness of these intervention types. And further research is needed to provide high quality evidence on other communication approaches for professional audiences. So we have a very limited evidence base to guide our communication practice in terms of communicating results to healthcare practitioners and to policymakers. And there's a real need to build the evidence base for more feasible approaches. Outreach approaches are probably effective, but they are very resource intensive, and it's hard to see how many of our studies could actually employ these realistically. Conversely, knowledge broker services require very little in terms of resources from the researcher themselves, because these services are already kind of up and running. And so whilst the evidence base isn't that solid on that yet, it's a low cost strategy for communicating our results. And so it's something that we should be trying to encourage knowledge brokers to cover our studies. I think the other thing which I've taken for this away from this is the need to target our communication at a particular audience and make sure that we're communicating it in the way that's effective and appropriate for that audience, rather than trying to use the same approaches for all our different audiences. So I'd like to thank my supervisors, Claire Vale, Julia Bailey and Max, for their guidance on this study, and particular thanks to Claire, who screened hundreds of full text articles for this project. My various references are available on these 3 sites. If anybody's interested in a particular one, I can post those in the chat. Thank you.